Thank you, Mr. Speaker and honorable senators. Let me, Mr. Speaker, first apologize. And I think it's on my side that going forward, I will comply with the standing orders and provide the answers. Not even 24 hours, but 48 hours. These I even had to raise with my staff this morning. And it's an oversight. It will never happen again. Honorable Speaker, on the first question, on why, what is the current annual budget, question one, which the senator has said, my answer is this. The Linda Mama program is not currently administered under the Social Health Authority infrastructure. While the program was instrumental in expanding access to free maternal care, it is important that it faced very critical challenges that necessitated a shift to a more comprehensive and sustainable model. And these were all anchored in the 4 laws that were passed by this House. These challenges, Mr. Speaker, included frequent financing constraints, budget cuts, delay reimbursements, significant access and equity gaps, especially for adolescent mothers without identification, and a benefit package that was not comprehensive because it was excluding critical maternal and newborn services like complications and the NICU care. And in response, Mr. Speaker and honorable senators, the Ministry of Health, through the Social Health Authority, has adopted a very comprehensive household coverage model to ensure all vulnerable families can access a broader range of essential health services. And that's why, as part of this strategic framework, the national government, through SHA and the Ministry of Health, is sponsoring 558,000 indigent households, which were identified through the State Department for Social Protection Enhanced Single Registry in order to access healthcare under SHA. And this is ongoing. Governors have come in, members of parliament, and many other philanthropists are coming in to support this program. Furthermore, recognizing teenage pregnancy as a very critical public health challenge in our country, the Social Health Authority has also introduced a very deliberate, targeted intervention for adolescent mothers and their newborns, leveraging digital health platforms and using our community health promoters. SHA now can facilitate real-time registration of these vulnerable groups, ensuring equitable access to subsidized care. And I'm happy to report that to date, 22,000, since SHA came into being, 22,000 teenage mothers across our country have accessed maternal services free of charge. The allocation of funds now operates on a fee-for-service model where funds follow the patient via claims, and this has replaced the previous fixed pre-allocation sort of budget. Question B was on the benefit package of Linda Mama. Honorable Speaker and members, the transition under SHIF has significantly expanded the former Linda Mama benefit package from a very narrow maternal focus to a very comprehensive household coverage model, now known as Linda Jamii Scheme. While delivery services remain very central, reimbursement has improved through a fee-for-service model, and which is aligned with the actual service cost, and this has given us and strengthened inclusivity for all vulnerable households across our country. And the table, Honorable Speaker, that I have provided shows the scope of coverage under Linda Mama and under the new SHA program. I really don't want to go. It shows the reimbursement model, the eligibility, the scope of coverage. And if I pick on, for example, the scope of coverage, under the, before Linda Mama, this was limited to maternal health, ANC, formal, and C-section delivery at our primary network centers. But under SHIF and SHA, comprehensive household coverage, which include outpatient, inpatient, emergency and surgical care, chronic disease management, maternal and newborn care, including all the complications, is now covered under the Linda Jamii. If you look at the reimbursement model, Honorable Speaker and members, under the Linda Mama, there was a predetermined fixed rates paid by NHIF. There was, the fee for normal delivery was $2,500 for level 2 and 3, and $3,500 for private and faith-based level 2 and 3, and $5,000 for public facilities, and $6,000 for faith-based facilities and private level at level 5 and 6. C-section was Kenya shilling 17. But if you look at the fee-for-service model under SHA, SHIF, the facilities reimbursement is based on the actual service rendered at the approved tariff rate and passed by the House. And then there's standardization of the reimbursement. Now, both faith-based, private, and public, women can have delivery, and SHA will reimburse $10,000. For cesarean section, $30,000 because of equity, whether they go to public hospitals, whether they go to private hospitals, whether they go to faith-based hospital. And then eligibility is different. Under the Linda Mama, eligibility was only targeting pregnantly, but adolescents and undocumented mothers were often excluded. But now if you look at the Linda Jamii or the SHA SHIF, under this transition, indigent households are identified via a very proxy mean testing as per the law, as per Section 27 of the Social Health Insurance Act of 2023. So pregnant, adolescents, and newborns are all included through a very targeted intervention using a temporary ID, and the entire household is covered under the SHIF comprehensive. So where the teenage mother can either use her birth certificate, she can use her parent identification, and the system has created a special ID to identify those important section of our mothers who are the teenage mothers. Question 3 about the safeguards. Honorable Speaker and members, several safeguards have been initiated to ensure that the funds are allocated for maternal and child health services, and that vulnerable mothers receive full benefits without undue delays. And what have we done? We have done, number one, we have introduced legal and policy safeguards. The Social Health Insurance Act of 2023, which this House has passed, mandates proxy means testing to ensure that only eligible vulnerable groups are covered, and this is anchored in the use of the funds within Section 27. 2, and more important, digitization and transparency. Reimbursement are processed through digital platforms that validate service for payment. They minimize fraudulent claims. Real-time registration is done through digital health platforms. Our community health promoters help us to instantly enroll, to ensure timely access, especially in the most remote part of our country.